Hello, everyone. We're just waiting for people to join the room, um, but I think we'll start. Welcome to the first of a series of 4 webinars that are going to be covering the recent papers that have looked at standards for the care of people with cystic fibrosis. My name is Kevin Southern. I'm a professor of child health in Liverpool, and I'm the current director of the ECFS Standards of Care Committee. And I'm joined today by my friend and colleague, Carlo.
Well, good morning or good afternoon, depending on where you are to all. I'm Carlo Castellani. I am a pediatrician and a clinical geneticist. I've been working in CF since 93, and I've been repeatedly involved in coordinating or contributing to ECFS standards of care documents, including the latest edition of the standards of care coordinated by Kevin.
Thank you, Carlo. So this is a series, and today we're going to be discussing paper 1, which is around a timely and accurate diagnosis. We will reflect on some of the methodology that we've used to produce the paper. We'll look at some of the key content in the paper, and we will consider the key messages, and we'll outline those messages right at the start of the webinar. The webinar is being recorded and will be available for people through the ECFS platform. It will also be available as an audible resource as well. So a bit like a podcast, so you can listen to it when you're on your bicycle cycling to work or traveling on a train. And that's how we're going to run this series of 4 webinars over the next 4 weeks. It's a bit nerve-wracking to do this and not be hiding behind the comfort blanket of a PowerPoint presentation, but we'll see how it goes, and we're very much looking forward to it. It's very exciting. These papers developed through the need in our society and the consideration that we needed to update the standards for the care of people with cystic fibrosis. Carlo was the director of the Standards of Care Committee before me, and Carlo, we talked back in 2019 around the need for updating the work that you'd done previously. In 2018, your paper was published, but quite a lot's happened since then, globally and within our community, and that's really had an impact on how we think about our condition and how we manage it. So it was quite a tough task, wasn't it, Carlo, to put this together?
Yes, it was, but indeed, lately things are moving much faster than in the first years when we had started producing the standards of care, and probably the need to update them now comes earlier than in the past. And then, of course, we can't forget the fact that modulators have entered the scene and to a greatest extent changed it, and that has to be taken into account.
Certainly, the increased accessibility to variant-specific modulator therapy for many people with CF now has really changed the landscape of our community. And also, the pandemic did have an effect, and actually not a completely negative effect on our field, and many innovations came through from the pandemic, particularly around virtual clinics and virtual monitoring, and we'll discuss those in some of the later webinars. But we could see that actually a lot of the evidence-based framework that we used to determine the best way to look after people with CF was really not so relevant anymore because of the changing landscape that we had. So we knew we needed to move into providing a new update. And we wanted to do that in quite an agile way. And we put together a core committee, a really dedicated core committee of stakeholders, varying adult and pediatric physicians, allied health professionals, but also working in partnership with the CF Europe Foundation and trying to appreciate and reflect the position of people with cystic fibrosis and their families. Now, the core committee and myself and Carlo, we put together the framework for these papers. And initially, we wanted all this to be included in one paper, but it very quickly became apparent the size and scale of this undertaking was considerable. And after discussion with the Journal of Cystic Fibrosis, we moved to having 4 different papers, and really the themes of those papers worked out quite nicely, and we'll see that over the next 4 weeks. But the topic of the first paper was around a timely and accurate diagnosis. And what we did for all the papers and for this paper was the core committee, I divided the topics into sections, and we identified authors for each of those sections, and we wanted authors who were respected in that field, who were experts, who could do a systematic search, and who could provide a relatively small amount of information in a very timely way. And then those pieces came back to the core committee and were reviewed by members of the core committee, who would make changes, sometimes not many, sometimes quite a few, and then would go back to the authors. And so we put the body of the paper together. And I have to say, we were extremely grateful to all the core committee, but also the authors, for working so in such a timely manner and for making this process work so quickly. We also asked the authors to provide statements of key principles that they had underlined. And a lot of what we were doing with these papers was trying to develop principles of care, as opposed to hard facts. And there's still a lot of work to do, as Carlo alluded to. We have a lot of research that we need to do moving forward to know how to best manage people with CF in this current climate. And the statements for all the papers were then evaluated by a Delphi process, and we sent them out to many stakeholders who were invited to look at the statements, and they said whether they agreed with the statement or whether they disagreed, and if they disagreed, to provide the rationale of why they disagreed, and make suggestions of how the statements could be improved. And consequently, we did change and improve many of the statements included in all the papers. So really, that's a methodology that we incorporated to put together these standards, and it proved to be agile. It proved to be quite timely, and I think it worked very well. Carlo, what were your reflections on the process? Lots of pieces of work coming through to you on the Friday evening.
Yes, lots of pieces of work, but what I found particularly reassuring in a way is the fact that in the end, the very first draft, then seen by the committee, and from which all the statements originated and were then evaluated by a more general public, specialist public anyway, of course, where didn't go through radical changes, which reflects the fact that probably we really managed to express what was the feeling of a community in terms of standards of care. I'm speaking for the diagnostic paper which we're talking about today, but also for the other papers. And as I said at the beginning, this is kind of reassuring, because it says that, of course, with some changes and some and some personal view, which sometimes and understandably can differ, we're all moving in the same direction.
And there's good consistencies across the Atlantic as well, and we'll reflect on some of those as we go through the next 40 minutes or so. So the first paper was called a timely and accurate diagnosis, and a timely diagnosis has always been really important in the world of cystic fibrosis. We think about the families who are involved in the diagnostic journey, how difficult that is. But we also reflect now on newborn screening, which has expanded to many areas and countries across the world. And actually, it's really key element of newborn screening that it's undertaken in a timely way. There's no point in screening if there's a delay in actually them processing the result. And this has become even more pertinent now with regard to the fact that CFTR modulator therapy is becoming more available, and we want to get those therapies into earlier and earlier aged infants and even into babies. So that's become very pertinent, and also reflects the fact that an accurate diagnosis is also key. And I was really interested to hear one of my colleagues from a large adult clinic in the UK speaking last week, saying that they had actually undertaken a repeat genotyping of all their adult patients because they reflected on how key this was for them. And although genotyping is very reliable, you can never be completely sure that a mistake hasn't been made in the past. So that was fascinating to me to hear that perspective on things. And what we're going to do with each of these webinars is we're going to outline 3 key messages that we have considered from the paper. And we'll do that now. We'll do that at the beginning of the webinar, and then we'll finish off the webinar with the 3 key messages again. So the 3 key messages from today, and I'll just go through them one by one, then we'll reflect on them individually. So the first key message is that sweat testing remains a key cornerstone of diagnosis. We'll come back to that in a moment. The second key message is that with extensive DNA analysis becoming increasingly available for every service, careful characterization of changes, or as we call them, variants of the CFTR gene is important. And we'll come back to that again in a moment. And finally, for the rare cases where diagnosis remains unclear, referral to an assessment by a central specialized hub with diagnostic expertise is recommended. So that's kind of a new thing that came out of this process. So we're saying that actually we need to be setting up these diagnostic hubs that have got the expertise to do more involved electrophysiological measurements, and we'll reflect on some of those later. Often in the past, these type of centers have been based around research groups, research projects, but actually moving forward, we need to have this diagnostic expertise focused in on these diagnostic hubs. And this is a piece of work that the Standards Committee, working together with the Diagnostic Network Working Group, will be trying to better characterize these diagnostic hubs as we move forward over the next 5 years. So those are our key messages from the paper, but there's a lot in this paper, and I do recommend it to you. And I think in the chat, Helen has been putting the PubMed ID numbers for all the papers, well, for a number of the papers that we'll be mentioning today. And so basically, you just put that number into PubMed and the paper will come up. Or you can email me and I'll send you a PDF of all the papers. So sweat testing remains a key cornerstone of diagnosis. That seems really obvious, but actually that's been interesting. I mean, about 25 years ago, a professor of molecular genetics said to me, he said, we're going to make your sweat test irrelevant over the next 5 years with the expansion of molecular genetics and understanding the CFTR gene. Actually, that didn't pan out. I never really believed it, to be honest. But the sweat test now remains as important, and actually has had another importance in a surrogate measure of new therapies that correct the underlying defect. So really, sweat testing is tremendously important, and there's been a lot of excellent work undertaken by the European CF Society, driven by the Diagnostic Working Group and led by Natalia Corelli. And that's one of the papers that's highlighted. And I recommend that paper. And it's really important that everybody keeps their sweat testing services working well with high quality of sweat tests delivered. The reason that sweat testing has not become obsolete is because everything is really complicated in the genetics world, and the increasing complexity of genetics has become apparent over the last 2 decades, and that's really fascinating in itself. And now we have this tremendous understanding and vision of the CFTR gene in its entirety. We do see that many of the changes, or as we call them, variants of the CFTR gene, are not directly associated with causing cystic fibrosis, and in some cases don't have any effect on the function of the CFTR gene to make the protein. In some variants, actually, there is an impact on the function of the CFTR protein, but it doesn't always result in the clinical characterization of a condition that we would call cystic fibrosis. So those would be variants of varying clinical consequence. And this characterization is really going to be key moving forward. And probably for me, one of the biggest and most important exercises and innovations over the past decade, and probably longer actually, Carlo, has been the resources that we have available to characterize the CFTR gene. And one of the key ones is CFTR2. Now, you've been involved in CFTR2 from the early stages. When did that start, Carlo?
Well, I think it's more or less 10 years now. I mentioned before, I was participating in a number of guidelines, and the very first one was about the use of mutation analysis in clinical practice. And that was a much needed paper at that time, because there was quite some confusion about how genetic analysis should be used, and about the increasing number of mutations we kept detecting. Few information were available about their actual pathogenicity in terms of causing cystic fibrosis. So, I mean, I think that paper fueled the awareness that we needed something like CFTR2. And actually, the USCF Foundation started this process, and basically it has never ended, because from the very beginning, when the number of mutations we could evaluate, and they came from registries or from big centers in Europe and in the US, more and more areas of the world have been involved and have sent the data which are necessary to CFTR2. And the number of mutations we managed to assess in terms essentially of saying if they can cause a CF or not, it has been increasing. If you go to the website, in the very first page, you'll find a link to another page which is going to tell you how the number of mutations which have been evaluated by CFTR2 has increased over the years. And the latest number is more than 1,000 CF-causing mutations now included, which is really a huge number. It's
That's more than I anticipated. They would be successful at characterizing, Carlo, because I thought there would be a sort of ceiling. Because a lot of the challenges, some of the variants, well, you call them mutations. I tend to use the word variants. Um, uh, uh, I guess with when you use the word mutation, it kind of it suggests that there's going to be an abnormality, and sometimes there isn't an abnormality, I guess the two are interchangeable. But I thought that there would be a ceiling at about 300 or 400 variants, and then after that, they would simply not be able to gain enough information to give a clear characterization of whether a variant was CF causing or not. Maybe you could outline how CFTR2 works, how they characterize the variants or the
yeah,
mutations.
yes, absolutely. And about using mutations, you know, that well, um, I started in a time when mutation was the term, and then that sticks to my mind, and I keep using the good old term. But you're right, a mutation in the mind of many is associated with causing disease. Variance is not necessarily associated with disease. There may be variants who have no consequences or consequences of a limited impact and not sufficient to generate a CF disease. So how is the system working? Well, basically it's based on a number of clinical data coming from the registries or the centers, and they are the pancreatic status, they are the pulmonary function, they are the Pseudomonas infection or colonization, better, and these are probably the most reliable data you can collect from registers, even if we must be aware that registries are something fantastic, but there may be sometimes some errors in including data. Now there are good quality control systems, but there may be room for some misunderstanding here, especially in the past with the PSPI attribution. Then we collected the sweat test values, and considering what Kevin just said about the importance of sweat test, of course, it's something which is very helpful in understanding the clinical impact of a variant in CFTR. What else we do is we try to assess in vitro either the function or the quantity of the protein produced by the individual mutations, and that helps us to understand if they get to the stage of being called CF causing or not. There is this kind of arbitrary, but based also on data collected along many years, that says that CF causing mutations are included in the range from 0 to 10% of wild type function, although the majority of severe mutations are much lower, closer to 1, 2, or 3% of wild of function. And then, of course, we have another way of assessing mutations, and that's kind of an epidemiological way of looking at them. When we started CFTR2, we used a large panel of genotypes coming from fathers of children with CF. So we knew then the genotype of these babies, and when we wanted to assess a new mutations, we looked if that was present in the DNA of the fathers. And of course, we did not expect that a CF causing mutation was present there on top of a mutation the father already had as a carrier. Otherwise, the father himself would have been affected by CF. or CFTR-related disorders, which is improbable because they have children, so they weren't even CDAPD people. That worked very well for the relatively more frequent mutations. Nowadays, we're working with much rarer mutations. The ceiling you are mentioning, Kevin, now has been overcome, but we need to use other techniques. We need to compare the frequency of the mutations in CFTR2 to the frequency in the large databases of mutations in the population. One of them is called NOMAD. Comparing them, we have a better idea if a mutation may be non-CF causing. And if we put all this together, the population data, the function data, and the clinical data, in the end, we can say for a large number of mutations if they are either CF causing or variant clinical consequences or non-CF causing, or if we have to keep them in the VUS area, which is variant or unknown significance.
But sometimes when you go on to the website, and I recommend to people to explore the CFTR2 website, it's tremendous. It's got a very good interface. When you put your variant in, there's no information on it, and that can be disappointing both for the professionals but also for the family. And actually, what you can do then within the website is you can ask them whether they do have any information on this variant, and there's a mechanism to do that on the website. And they often do have extra information on variants that have not been included in their spreadsheet to date. So I recommend people do that. I also, to my families who have variants of less clear significance, I recommend that they visit the CFTR2 website, because the information it is a very well laid out website that lay people can access, and it's quite clear. So I do recommend it to my families. Carlo, do you think many families access the CFTR2 website, or?
Well, I don't have precise data, but I think they do. Of course, there is a language barrier. CFTR2 provides for all world around, but it's in English.
It's English. Well, it's based in Baltimore, and it came out of Gary Cutting and his team, Karen Rare and Patrick Sosney when he was there, and many other members of the team. It's a tremendous resource, and as we said, we do recommend it. And thank you for flying the European flag as part of the CFTR2 team, Carlo. You've been an integral part of that. We also have another resource in Europe, which is CFTR France, which is run out of Emmanuel Girodon and Caroline Rane, and their team, and that's a big database of CFTR variants, but it is slightly different to CFTR2, Carlo, isn't it? Do you want to kind of explain the differences?
It is different, and it is good it is different because it gives you a different perspective. It is different in a way that it collects data not only from registries, and in this case specifically the French patient registry, but also from newborn screening, from genetic counseling services. So from a world of CFTR variants, which is absolutely not present in CFTR2. And this is good because it makes you explore areas like CFTR-related disorders or similar situations, which are, strictly speaking, are not included in CFTR2. Also, what may be more difficult in the comparison between the two is that they use different denomination for the variants they assess. Because CFTR2 has the ones I just told you before, the VDCC, the non-CF causing and the CF causing, while CFTR France has the two extreme, the disease causing the non-disease causing, and then in the middle, an area of 4 grading of DUS from 1 to 5, where you may be closer to CF causing or non-CF causing, which gives you an idea of a continuum, which it is, because it is a continuum function, but sometimes makes it more difficult to understand what the real impact is. Another difference is that because a lot of data come from genetic counseling service or newborn screening, there is a lack of clinical information, and that's sometimes disappointing. But the two together certainly cover two main areas and are complementary.
So CFTR2 is very much focused on cystic fibrosis. It's very much focused on you have a condition, cystic fibrosis, and this is a characterization of variants associated with it. Whereas in my mind, CFTR France is a broader database of all CFTR variants. And for example, a variant might be characterized in CFTR2 as non-CF causing, not associated with cystic fibrosis, whereas that variant might be in CFTR France and might be associated with some slight dysfunction of the CFTR gene, and could possibly be associated with a CFTR related disorder. And we'll touch on CFTR related disorders in a moment. So they are quite distinct, the two databases. But we recommend strongly that you engage with them. They're accessible. Personally, I find CFTR2 a bit more easy to navigate, but CFTR France is also really, really very useful and very good. So we'll move on now to talk about some situations around an unclear diagnosis. So in the paper, it kind of outlines approaches to newborn screening, which is very interesting. It talks about diagnostic criteria, and in the chat we have the key diagnostic paper, the Farrell paper, that really firms up the CF diagnosis. But we want to spend the next 20 minutes or so talking about clarifying unclear situations or unclear diagnostic situations, and possibly the area that has become increasingly common is around a positive newborn screening result. So an infant has a newborn screen for CF, the result is positive, so they have a positive newborn screening result, but then their testing doesn't fulfill the diagnostic criteria to make a diagnosis of CF. And most importantly, the infant is well. So you have a well infant who's had a positive newborn screening result, but they don't have a clear diagnosis of cystic fibrosis. And that can be a couple of things. So they could have two CFTR variants identified, but one of them is unclear, it's unknown as to its characterization. Or they could have an intermediate sweat chloride result, so a sweat chloride result between 30 and 60. But these are well infants, and it's an unsatisfactory situation for the families. It's kind of quite a psychological roller coaster ride, having a positive newborn screening result and then being told that their child doesn't have cystic fibrosis, but actually they're in this situation where they have this designation of CF SPID. You may see it written as CRMS CF SPID, and that's confusing, and we appreciate that, but that's because in the States, the designation has been called CFTR-related metabolic syndrome, or CRMS for short. And some time ago, we worked together with our colleagues in the States, and we harmonized that definition into CRMS CF SPID, which is quite a mouthful. But in papers, you might see it written as CRMS CF SPID, and that's good because we're all, if you like, singing from the same hymn sheet. Now, we had some questions, and thank you for sending questions through. That was really kind. Some of the questions were around the management of infants with CF-SPID, and I think this is an area that is challenging, but it's an area that we've made tremendous progress in over the last 15 years. And the most updated guidance is in the chat. The PubMed ID number is there, and that was from the European CF Society. And that was really reflecting on the journey that these families and these infants can go on, and some of them, and a proportion, will convert to a CF diagnosis, and that conversion can be either through an increase in their sweat chloride so that the sweat test goes into the diagnostic range, or it can be that we have more information around their CFTR variants, and that CFTR variant has been identified as being CF causing, or it can be that they develop clinical features consistent with a diagnosis of CF. So there's a number of ways that these infants can go. Most of them, though, will remain well, very well, and not develop any of those symptoms. And in the last guidance, we reflected on, well, if we have a child who's getting towards their school age, maybe 5 or 6, who is very well, who's had no symptoms that are suspicious, who has a completely normal sweat test, and maybe some limited investigations like respiratory function testing, possibly some limited imaging, are reassuring and normal. Maybe there could be a conversation with the family at that point, and it could be considered whether that child could then be managed in a more primary care situation. Where obviously the family would need a lot of information, and that could be an option that's given to the family. This is quite contentious, and we'll need to monitor this because these children, because of the genetic because of the genotype they have, we consider that they are potentially at risk of developing a CFTR related disorder as they move into through their young adult life, and that's something that the families need to be aware of, and the individual, the child themselves, as they go into their adult life, they need to be aware of that as well. And I think probably now would be a good time to move on to considering around CFTR related disorders and talk briefly around those. But before we do that, maybe just mention that the CF Foundation have recently produced their guidance on the management of infants with CRMS CF SPID, which are very consistent with the European CF Society management, but a bit less clear around discharging patients at the age of 6 or 7. So some sort of some slight conflict there. I think the key messages with regard to CRMS CF-SPID are that you need to be consistent as a team. You need to be consistent in the information that you give to these families and how you manage these families. What these families report to us as researchers and as healthcare professionals is that when they get inconsistent messages is really unsettling for them. It undermines their faith in the healthcare professions, and it's really quite distressing. And also they need to know what journey they're going on. They need to know why we're doing sweat tests at age 6, and they need to know that there's a possibility that actually they might convert to a CF diagnosis. That shouldn't be a surprise to them, and that's why we're following them up. And when they do convert to a CF diagnosis, most of them, virtually all of them, will be eligible for new therapies like the modulator therapies. So these are really important and difficult decisions. And clear pathways are needed for the families. This is one of the key messages that we should be giving out today. Sorry, another key message. We've given 3 key messages already. But anyway, some of these infants will move on to have. Sorry, Carla, you were going to.
Well, I was just going to say that this is always true, and also, of course, for CF. But once again, what is extremely important is the communication of diagnosis. But if you want to call that a diagnosis, it's not even a diagnosis, it's a definition. Let's say the initial communication, because the point here is that what we have to say is that we don't know. We don't know what's going to happen to that specific child. Maybe it will evolve into CF, maybe it will not. It is true that we may have an idea, depending on the value of sweat test or the kind of mutations we have found, but it's not a certainty. Surely that makes the communication more difficult for the clinician and, of course, for the family. But if well explained, as Kevin said, and followed consistently, keeping the message, most families go through that reasonably well, I would say.
Yeah, I think the situation has improved considerably, Carlo, since the production of the guidelines, the guidance. There is much more consistency across Europe with how we evaluate and how we manage these infants. I think there's still work to do, and we need to manage these families really carefully. We desperately need good information and data on these families, and it's very important that we move towards developing a European registry of these infants, so that we can follow up their long-term progress and outcomes, and we're working strongly in the society to do that over the next year or so. So that will be a tremendous resource for our community. So we're going to move on for the final part of the webinar, just to talk briefly around CFTR related disorders. And Carlo, maybe you could just sort of define what we mean by that term.
Yes, well, the definition is quite clear. What may be difficult is then to put it into practice, but the definition says that there are three components. It has to be a clinical entity with features of CF, and traditionally these have been the congenital bilateral absence of vas deferens, or some forms of acute recurrent or chronic pancreatitis, or some forms of bilateral bronchiectasis. But there may be more of them, and we may speak of that later. Then what you need is some evidence of CFTR dysfunction, but in a context of dysfunction which is not the CF level, 0, 10%, I mentioned that before. It's usually said that it should be between 10% and 30%, and then at 50% you have the carriers. And then you must exclude the diagnosis of CF, which maybe we gave it for granted, but as we are talking about CF diagnosis, it's better to say again that you can make a diagnosis of CF if you have at least one among a compatible clinical situation, or a positive newborn screening test, or a SIB with CF. That's the old way of saying it. Now I prefer saying two carrier parents, which is the same as saying a SIB with CF, but that makes you make a diagnosis also in the prenatal phase, plus the positive sweat test, or two CF causing mutations, or an MPD or ICM compatible with CF. So that's CF. And if you don't satisfy these criteria, you can think of a CFTR-related disorders if there are the clinical manifestations I mentioned before, and if there is a certain degree of CFTR dysfunction.
So the initial presentation of this disorder was around 2011 from the European CF Society exercise and the Bombieri paper, and that was just one paper. But recently, Carlo, you on behalf of the committee have led a big exercise, sort of revisiting and updating that characterization. And that's taken 4 papers to do. Well, why 4 papers now and only 1 paper back then?
Well, probably like for the standards of care, the initial idea was to just produce a paper, maybe a large paper, but then we realized that there were so many things to say, so many aspects to consider, that it really made sense to split them in 4 papers and try to be as comprehensive as possible in each of the paper regarding the specific topics of the papers. And so the first paper is about the definition, and I just told you what the definition of CFTR-related disorders, and by the way, it is exactly the same as the definition used in the previous guidelines of 10 years before, because we believe it is an excellent definition. As I tried to say before, the problem is that applying it to real life, and that's what we tried to be more specific about in the papers. In this first paper, we also explain why it was time to update and give more information on CFTR-related disorders. We give some hints on the first clinical evaluation and the follow-up of people with cystic fibrosis, generally, with CFTR-related disorders, generally speaking. And we express the idea that there may be other clinical conditions which we may call CFTR-related disorders in very specific situations, and they may be chronic lymphosinusitis, they may be aquagenic wrinkling, well, now I don't even remember all the others. They are all in paper 3, examined in details in terms of exclusion of other diagnoses, in terms of making a specific diagnosis and follow-up. And that's paper 1 and paper 3. In paper 2, that's completely devoted to the assessment of the dysfunction of CFTR-RD. I mentioned the 10 to 30% level of dysfunction, but how do you actually measure that or assess that in the individual you have in front of you? You have to evaluate in order to understand if he may have or she may have a CFTR-related disorders. And then we suggest the possibility of using the sweat test, which is an individual indirect marker of function. We use it also to assess response to modulators, so to the rescue of function. And the other way, which is easily accessible, like sweat test, is mutation analysis, which is a very indirect way of assessing function, but of course there are data connecting specific variants to a certain degree of CFTR dysfunction, so you can use that and the definition of these mutations. And then you go to the electrophysiology measurements, ICM and PD, which are very good at saying one has a CF or someone does not have CF. More difficult to interpret to say if this is CFTR-related disorders, but they are anyway an important tool, and even more necessary to use in hubs with the necessary expertise in interpreting that. And then there are also the description of some experimental methods which are not standardized yet for assessing function. And finally, the fourth paper, and that includes a number of topics like CFTR-RD, should they be included in registries? And as a matter of fact, they already are in at least a couple of registries, US and Germany. And probably they will be more and more included in CF registries, labeled as CFTR-RD. Also in consideration of the fact that probably there are already some CFTR-RV patients in CF registers with a mislabel for a number of reasons. And it was also about, I'm again talking about paper 4, about clinical trials in CFTR-RVs, because this has never been done before. But if we want to use medicines for CF and specifically modulators in CFTR-RV, probably we need also the support of a clinical trial for regulators. And then genetic counseling and CFTR-RV disorders, exactly because the mutations involved are mutations which may have a variability in clinical impact. The genetic counseling is much more complex than a standard CF genetic counseling, where everything is much more predictable. And then also something about that was mentioned before by Kevin, what we know about the possible evolution from CF SPID to CFTR related disorders. And here the answer is we don't have enough time yet to say if this is a real possibility. So as you see, it's a lot of topics, and that I think explains very well why we needed 4 papers.
Yes, it was a tremendous piece of work, Carlo. Congratulations on leading it. I particularly like paper 4, where you're translating this knowledge into sort of the reality of practice. We've got one final question. We're running short of time, and this is probably the most tricky question that we've received. So, is it appropriate to label a patient with symptoms suggestive of CF, for example, recurrent airway infection and bronchiectasis, who doesn't fulfill the CF diagnostic criteria as a CFTR-related disorder, or might this restrict their access to modulator therapy? Could you just answer that very briefly, Carlo, because we haven't got much time there? No, it's a really tricky question.
It is a tricky question, but I can understand very well that, especially if a CFTR-RV patient has lung disease, important lung disease, or even upper airways disease, and that's due to CFTR dysfunction. It's in the definition of CFTR-related disorders. It makes sense to think that recuperating, rescuing dysfunction through a modulator should improve the situation of that patient. And indeed, on an anecdotal way, that has been proved in several cases. So, yeah, the rationale is there. What we don't have is the trials showing it in a systematic way. And also, I would like to point to the fact that if you move someone to a diagnosis of CF, you're moving him or her to a completely different situation. CF is still considered a life-limiting disease, and CFTR-related disorders are not. So, I mean, that may
It's a big move. It's a big move for the person. Yeah, yeah.
Insurance point of view for countries where health care is linked to insurances. So I think there are many pros and cons to keep in mind before moving in this way, which has probably a rationale anyway, as I said.
So that is a tricky area, and I think that's a great answer, Carlo. But I think it's really important that we keep an eye on this. And obviously, a lot of these patients who have a CFTR-related disorder will have eligible variants for modulator therapy, and that's something that, as modulator therapies become more accessible, will be considered. So that we have covered a lot of ground. And we could probably carry on talking, myself and Carlo, for another few hours, but I'm sure that none of you want to hear that. So I'm going to finish now with the key messages again. So message 1, sweat testing remains key. It remains a key cornerstone of diagnosis, and now a surrogate outcome that is quite useful. Secondly, get to know CFTR2, get to know CFTR France, the improved characterization of the variants of the CFTR gene has been a major step forward in our field, and something that we should embrace, and is really important. We talked a lot about that today. And finally, we need to establish diagnostic hubs across Europe and probably globally, places, centers that have special diagnostic expertise. Now, you would expect all good CF services, all good CF units will be able to cope with the day-to-day diagnosis of a person with cystic fibrosis. But when it's tricky, in the rare cases, other electrophysiological measurements are needed, or more extensive genetic testing is needed, then we need the expertise, and we need the expertise focused in diagnostic hubs, and that's an area we'll be working on with the diagnostic network working group over the next few years. So it's been tremendous fun to chat with you, Carlo. I hope people have enjoyed it. This is a new journey for us, so I mean, if you feel it's been good, let us know, and we'll see how the webinars progress over the next 4 weeks as we review papers 2, 3, and 4. So thank you again, Carlo, and have a nice afternoon or morning wherever you are to everybody.
Bye.
Bye bye. Bye bye.